Good morning, everyone, and welcome to Tall Rounds. Today, we are going to discuss the contemporary treatment of end-stage heart failure. Is it time for a new heart? We'll explore some of the treatment options for end-stage heart failure, talk about multi-organ transplant, other options if we don't have a heart, such as durable mechanical circulatory support. Dr. Najim will discuss congenital heart transplant, and we'll also feature some interesting new developments in donor heart procurement. And lastly, we will learn about the outcomes of heart transplantation in the modern era. But first, to begin our presentation, I would like to invite our fellow, Dr. Al-Hassan, up to provide a case presentation.
Start with our case presentation. As heart transplant case presentation is 62 years old, male with history of non-ischemic cardiomyopathy with AF of 15%, status post-ICD implanted and recurrent VT and VF, and post-ablation maintained on amiodarone. Given his recurrent VT not suitable for LVAD, was listed as status 2 for heart transplant. This is some echo picture of his heart.
Welcome, everyone. The treatment of current heart failure has been cemented by these four pillars of sacubitril, valsartan, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. And in addition to that, we then tend to customize based on populations and response other agents such as diuretics, hydralazine isosorbide, hebravitine, viriciguat. Based on recent data, we know that after patients have been hospitalized with acute heart failure and there is an intense up-titration and follow-up of these patients, congestion tends to stay down and decrease after, and then as well as there's an improvement in mortality and a decrease in heart failure readmissions. Also in the long term, we have an improve, actually additional improve of each of these agents in survival over time. So it is actually a quite dramatic change between having no medical therapy to have it all agents combined. I'm briefly gonna just mention those things, but there are other treatments and procedures, of course, that we use, such as iron replacement, atrial fibrillation, ablation when needed, IV nodal ablation, CRT, CPAP, bypass, etc. That obviously I'm not going to go into it, but there's many things that are being done sequentially over time. And in recent years also there's been an explosion of devices. In addition to ICDs and CRTs that we know, now we have approval for the transcatheter H2H mitral valve and tricuspid valve repairs, AVRs, cardiomems, barostims, and CCMs, or cardiac contractility modulation, and now the up-and-coming combination of CCM and ICD that we are also implanting here at Cleveland Clinic. This is not really a sequential model. It should not be a sequential model in which we leave procedures or devices at the end of the road, but actually has to be integrated along the heart failure care, trying to not only start and maximize medications, but also seeing avenues to add devices when needed throughout this pathway before we get to advanced heart failure. The advanced heart failure has been historically defined by New York Association class, and more recently in terms of INTERMAC profiles. But there's a mnemonic that was created back in 2017 that actually has been recently adopted by the heart failure and ICHRT guidelines. Is called I Need Help. And I Need Help stands for the use of previous or ongoing inotropes, advanced New York Association class or elevated natriuretic peptides, end organ dysfunction, low ejection fraction, frequent defibrillation jogs, hospitalizations for heart failure, persistent edema, hypotension, or inability to titrate medications. And all these are markers or surrogates the patient's actually in advanced heart failure state. When patients are in advanced heart failure, now that should trigger an evaluation for advanced heart failure therapies, in particularly heart transplantation, after discussion with the patient. And we use CPET as a marker to quantify exercise intolerance as well as prognosis. And then it's also recommended to measure hemodynamics because the current allocation system since 2018, actually has a great focus on hemodynamics, particularly in the presence of low output or cardiogenic shock. You can see this is a list of priorities. There's status 1, highest priority, status 6, lowest priority. And you can see that the patients on a status 1 are the patients who are, and this is a simplified scheme, but patients that are supported with surgical devices such as VIVADs or ECMO, Centromax or ECMO. Status 2, patients on percutaneous temperature support devices like balloon pumps or Impellas. Status 3, those that have a complication with their LVADs or have multiple inotropes. Status 4 are the special populations like congenital heart disease, or they have an LVAD, or a durable mechanical device, which by itself would require for patients who have a low output state to begin with. And status 5, multi-organs. And then a status 6 is the rest of the INTERMAC profiles, 4 to 6, which I just talked about. So there's a big, great interest. This has led to an actually increase of patients being transplanted in less than 90 days since 2018, actually. And the rest of the patients that have been waiting less than 3 months, it continues to go down. And that has been at expense of a very rapid increase in patients listed for status 2 and a status 1. It has led to an increase of transplants in all types of cardiomyopathies, but again, the rates are highest on patients on a status 1 and a status 2 are the ones who are mainly transplanted. So we know that the VE ECMO has not shown to improve survival so far in cardiogenic shock. However, when we decongest the ventricle to decrease the pressure volume area under the curve and myocardial oxygen demand, this seems to be an improvement in mortality compared to regular ECMO, but that, at least in the current data, some patients that have been decongested or at least put on Impella in less than 2 hours since ECMO. But we do use ECMO increasingly now for the bridging of advanced heart failure therapies. You can see both LVAD and transplants. However, there's a cost to pay in which even those patients that make it to transplant after being supported with ECMO still have a lower survival even after a year. So something to keep in mind. Survival is about, if you think about it, mortality in ECMO is about 50% after 10 days. So that is something to ponder on. Balloon pumps have not been shown to be of survival benefit in the management of cardiogenic shock. However, we do use them for bridging advanced heart failure therapies. There's 2 reports here, one from Houston Methodist, the other one's from Chicago. About 60% in one cohort and about almost 90% on the other cohort have been bridged to advanced heart failure therapies. The survival after being supported with these devices about a year after from transplantation is very good. It's about 87%. These patients are able to be ambulated, and we do this often in our unit. Impella has been so far the only device that has been shown mortality benefit in the management of cardiogenic shock, albeit with a little bit of extra bleeding and complications. But the big daddy of Impella, the Impella 5.5 and 5.0, has been recorded in the last 3 years in the cardiogenic shock working group here in the United States, and we see that the survival report is about 67%, but 46% of those patients actually have gone heart replacement therapies, either LVAD or transplants, and 80% of those patients that have had this actually have heart failure-mediated cardiogenic shock. And the survival of patients supported with Impella after a year that were transplanted is actually excellent as well. It's about almost 90%. There's been case reports of bipellas. So in this case, Impella 5.0 and RP. Cleveland Clinic reported the first one about 20 days of wait time back in 2019. And some of them have been bridged to LVADs, however, with a 50% mortality. So what is better, either an Impella or a balloon pump? And actually, this is a recent analysis of all the regions in the United States, over 4,000 patients. You can see that there's all these regions in the OPO as transplants, and there's a ratio between balloon pump to Impella. For example, in our OPO here, region 10 is about 7. So we use about 7 balloon pumps per Impella supported. Wait times are long, but as you can see, they've actually been decreasing in recent years. And overall, in the whole country, there's been a trend towards a decrease in balloon pump usage and an increase in impeller usage. However, survival has remained the same so far in all these patients. And finally, just to wrap up and ponder, this change in allocation status and being more aggressive in managing pre-transplant cardiogenic shock as a bridge to transplant with mechanical devices has led to an increase in heart transplantations compared to the prior allocation system, both in status 1 or 2, and a decrease in waitlist mortality, which is obviously important. However, it's actually been a decrease in the recovery of patients as well, right? Because we transplant them too fast, and it's less than 90 days, both in status 1 and status 2. So it's something for us to ponder. So thank you.
My role is to see how durable LVADs fit into the scheme that Emmanuel described. This was one of the first generation LVAD pumps, the HeartMate Ex-VE, back in the late 90s. You can see it's a bulky pump, requires a big pocket, intra-abdominal pocket. It's pulsatile, but despite how bulky and how impractical this pump was, in the landmark rematch trial, that's the wrong year, 2001, and in a very advanced population of patients with advanced heart failure on IV inotrope, we saw a dramatic improvement in 1-year survival, almost doubling from medical therapy of 25% at 1 year up to 52%. But that survival wasn't really sustained at 2 years due to LVAD complications and difficulty with managing this bulky pump. That survival decreased to 23% at 2 years. So up until this point in the 90s and the early 2000s, really heart transplant remained the standard of care for patients with advanced heart failure. But the rematch trial was the first thing that put LVADs on the map. And unfortunately, our technology has improved since that first pump back in 2001. We now have continuous flow devices with the HeartMate 2 and the HVAD, which were the first continuous flow. The HeartMate 2 is an axial pump, and the Heartware was a centrifugal design. And now they've been supplanted by the HeartMate 3, which is our current pump, which is continuous flow and has a maglev technology, and currently the only commercially available durable LVAD device. So the main pitfalls of LVAD technology, and this is something that we deal with till this day, in the bottom left box you see hemocompatibility adverse events, pump thrombosis, stroke, and GI bleeding. And this was the focus of the newest generation LVAD pumps, was to decrease this set of complications by making the pump more gentle on blood as it passed through and more hemocompatible. There's other pitfalls and other complications to think of, hemodynamic complications such as RV failure, AI, and also cardiac arrhythmias. And in the bottom right, infection, which remains an issue, especially with the external driveline. So this is our current pump, the HeartMate 3. It's a fully magnetically levitated rotor, which creates a frictionless path for blood to move throughout the pump. It's centrifugal, has large blood flow pathways, and has an intrinsic pulsatility, which is thought to improve the washout in the corners of the pump and prevent stasis. And all of these changes were aimed at preventing those hemocompatibility adverse events. And then the landmark trial, the Momentum 3 trial, which was also a very sick population, comparing the axial flow HeartMate 2 to the centrifugal flow HeartMate 3, we saw a dramatic improvement in the hemocompatibility adverse events with basic elimination of pump thrombosis, improvement in stroke, GI bleeding, but really no change in infection or arrhythmias or RV failure, but the hemocompatibility events were much less. This is our current pump. It's side by side with the last one. It's much smaller, much easier to work with. It fits completely intrapericardial, and it's become a very good option for patients with heart failure. Looking at our trends recently, in blue you see that the HeartMate 2, which was replaced by the HeartMate 3 in 2017, and then the HVAD in orange, which was taken off the market in 2021. So in recent years, the HeartMate 3 has become the exclusive pump for durable LVADs. And the outcomes have been excellent. This is the last Intermax data from last year, and the 5-year data with the HeartMate 3 in green is 63% at 5 years. And looking at the 1-year data, which about 86% survival, which is very close to that of heart transplant. And the complications are less GI bleeding, but still there, less stroke, but still there, and significantly less pump failure with thrombosis. And infection really remains a main issue with LVAD pumps, with at 4 to 5 years, almost 2/3 of patients having, or 1/3 of patients having some major infection. So the major benefits, and when we're evaluating patients for LVADs, we know that this very sick population has limited survival. We can improve that. We can improve functionality, quality of life, and that's at a trade-off for hospitalizations, especially in the first year, 1/3 of patients getting infection and still having GI bleed, heart failure, right heart failure, and other complications. But in general, this is a great option for these very sick patients to improve their outcomes and quality of life. And here at Cleveland Clinic, we've done, in 2023, we were the highest implanting center in the US with 81 devices. We're continuing to keep that trend up this year, hopefully. And our 1-year survival has been about 86% at 1 year, which is on track with the Intermax data. And our 5-year survival also better than the national average. So if we're looking at trends, where does LVAD fit with a heart transplant and advanced therapies? Since the allocation change that Emmanuel described, we've noticed a decrease in the number of durable LVADs as an option for advanced heart failure. And you can see that after the peak in 2019, there's been a steady and slow decrease in durable LVAD therapy. And that's been matched by an increase in heart transplants as we've gotten more aggressive with listing patients status 1 and status 2 on temporary support and using more donors with DCD and other options that we'll talk about later. But I want to point out that the total number of patients treated with heart transplant and LVAD has remained about that 6,000. So we're just trading off durable devices for temporary devices. But are we really treating more patients with this more aggressive transplant strategy? So that is to bring into question, is there still a role for durable LVAD, and should the numbers really be dropping, or are we just missing a patient population? So after the allocation change, now currently less than 5% of devices are placed with the bridge to transplant strategy. And that's been a recent trend since 2018. And that follows from the change in the allocation system. In the prior system, a stable LVAD was 1B on the list, which was a high status. And in the current system, a stable LVAD at home is a status 4. So programs that are trying to get their patients transplanted find that durable LVAD could increase the wait times for their patients. And so they're going for balloon pumps, Impellas, ECMO, status 1 and 2 to get their patients transplanted. And a durable LVAD has become less popular, for better or for worse. And as you can see here, patients listed with LVAD after the allocation change has come down dramatically since the allocation change. So what do? We have a patient in cardiogenic shock. Do we go direct to transplant, or is an LVAD better? And these are complex decisions. Direct to transplant, some characteristics that would be favorable is a multi-organ transplant, a heart, liver, or heart, kidney. If this patient has some bleeding predisposition and couldn't be on chronic warfarin for an LVAD, if they have a small heart that couldn't accommodate an LVAD, a poor RV, or a proclivity to VTAC, those patients were probably suited better with transplant, and that's what we've done in our program. Now, LVAD still has a role, and we still use it commonly. Patients with high pulmonary hypertension who may not be able to go straight to heart transplant, obesity, LVAD is a great option as a bridge to bariatric surgery or medical therapy for obesity, and potential for those patients that we're probably not capturing that are recovering after their acute cardiogenic shock episode, and patients with recent malignancy. So just to finish up here, the future of LVAD is bright. Despite the changes in the allocation system, there are discussions about that being revised again so that LVAD patients aren't penalized for having a durable device. And the devices are getting better and more hemocompatible, fully implantable, hopefully in the near future, and other changes as well. And these are some of the new pumps that are already on the pipeline. And in the middle there, you see the BrioVAD, which will be coming here to Cleveland Clinic shortly. And there's a trial, the Innovate trial, which we are enrolled in. So it's an exciting time for LVAD therapy. And thank you.
I'm going to talk a bit about how we can rejuvenate heart organs using Ex-Vivo heart perfusion. here are my disclosures. So I think it's fairly obvious that there's a massive underutilization of donor organs in the United States and actually globally, with last year in 2023, almost 16,000 total deceased donors, but we're only capturing a small percentage of those organs as heart transplants for patients. So there's a significant opportunity to grow transplant volumes across the country. Now, historically, we had a donor that was always a brain-dead donor. We would harvest or procure the organ at the facility, place it in an igloo on ice, so there would be an obligate period of cold ischemic time, rush it to our center where the patient, the recipient, is waiting, and we would implant the heart. That was the process we used for the last 45 years. Of course, we recognize, though, that there is damage from cold ischemic storage. There is cellular edema and acidosis, along with endothelial injury, and this leads, of course, to prolonged cold storage, or the prolonged cold storage leads to increased rates of primary graft dysfunction and decreased post-transplant survival. And if this looked better on the screen here, if you turn your heads, you can see that at 3.5 hours, that's the inflection point where we begin to see the penalty for cold ischemic storage. So why are we talking about donor heart preservation today? Well, the 2018 heart allocation change you heard about recently has led most programs to travel farther for donors and incur longer ischemic times. And additionally, as you've also heard, more and more of our patients, of our recipients, are on temporary MCS and are sicker, so these are increasingly complex recipients. Additionally, we've found a new source of donor organs, that is to say DCD hearts, that require resuscitation after reanimation and then evaluation on some form of a donor heart preservation platform. And finally, we've started to look at extended criteria donors. These are increasingly complex donors that, again, also need to be resuscitated and evaluated at the donor facility. So this is what it looks like today. The donor has multiple different options. There's not only the brain-dead donors, but we have DCD donors and extended criteria donors. We have a whole host of various options that are available for donor heart preservation. I've listed in yellow those that are really transport-only devices, in green those that resuscitate and transport, and those in red that only resuscitate. And then lastly, our recipient operation is no longer just an arrested implant always. When we use the OCS device, the Transmedics device, we can actually implant the heart while it's still beating and not incur a second hit, so to speak, with another cardioplegic arrest. So here is the Paragonix Sherpa Pack. This is a device that is taking over for standard cold ischemic storage. This preserves the heart in a single-use sterile disposable box, and it controls the temperature anywhere between 4 to 8 degrees centigrade. So this is basically the cardiac surgery version of the Yeti compared to the Igloo. The Guardian Heart Registry shows that in patients who had the Paragonix Sherpa Pack compared to standard ICE controls, despite a significant longer travel time and greater ischemic time in the Paragonix Sherpa Pack group, there was no difference in survival out to 1 year. And if you look at propensity matched pairs, the Sherpa Pack actually had lower severe PGD and need for temporary MCS after transplant. Here's the Transmedics OCS device, and this device is effectively a cardiopulmonary bypass pump where a heart is reanimated using donor heart blood, and then it is then packaged up, brought to the donor facility, and then assessed. Here's one in the operating room from a few weeks ago, and you can see the heart beating right before your eyes. The donor heart assessment can be made after modifying hemodynamic parameters during the trip, so we can change aortic pressure and coronary blood flow, and we monitor perfusate lactate level, and once the lactate level falls below 5, we deem that organ a good quality and acceptable for transplant. And of course, visual inspection adds to that assessment. So So the rationale for using the TransMedics Heart OCS was established in 3 trials. The PROCEED-2 trial, which is now almost a decade old, showed that the OCS was non-inferior to standard cold storage techniques. The EXPAND trial took this a step farther and showed that the OCS successfully preserves and assesses extended criteria donor hearts for transplant, and the outcomes were equivalent to standard brain-dead donors. And then most recently, the DCD trial, where the OCS was used to reanimate, resuscitate, and transport a DCD heart, and showed excellent graft survival comparable to brain-dead donors. And here's the DCD trial outcomes. Notice on the far left, there's no difference in post-transplant mortality with DCD using the OCS device compared to standard cold storage brain-dead donors. In the middle, you can see that the patients who had DCD hearts received organs faster, so a higher transplant rate. However, there was a slightly higher right ventricular dysfunction with the DCD OCS platform. But overall, the use of TransMedics has increased donor organ utilization, both from expanded criteria donors as well as hearts with DCD. In fact, if you look across the country today, most large programs, 20% of their hearts are DCDs. And I would say that there's also been an improvement in outcomes with experience using these devices, and particularly in using the TransMedics pump. The company has gone to a proprietary harvest team so that experience is really carefully managed amongst their team members. And what we've realized with that is a significant decrease in both moderate and severe PGD amongst these hearts. Here's the Ex-Vivo device. This is a hypothermic oxygenated perfusion device that preserves the donor hearts at 8 degrees centigrade with continuous oxygenated perfusate. And this is in trial right now. The difference between this and the OCS pump, of course, is this is not blood. This is a perfusate, a cold perfusate. And lastly, I want to mention thoracoabdominal normothermic regional perfusion. This is a method to reanimate and resuscitate a heart in situ. This is effectively modified cardiopulmonary bypass circuit, or ECMO. Patient is cannulated centrally after the patient is declared dead. Arch vessels are clamped so as to not provide any blood flow to the brain. And then there's in situ resuscitation of the DCD heart and visual in vivo assessment of the quality of the donor. The advantage here is that this is very inexpensive, but it does require a large bandwidth in the sense of both a perfusionist and surgeon and all to go to the donor facility. And there are ongoing ethical issues across the country. So in summary, I would say that there's significant improvements in donor heart preservation over our traditional cold storage. There's decreased PGD that we've noticed, which obviously is leading to improved clinical outcomes, but we're also expanding the donor pool. We're enabling utilization of higher risk donor hearts, and we're getting out farther to get hearts beyond our standard 800 nautical miles. But clearly the best outcomes are achieved by matching the donor heart and the recipient with the optimal heart preservation method.
It's my pleasure to be here, and multi-organ transplant is not something that we take lightly. To take multiple organs for a single recipient is really a gift that we really cherish. Over the years, our patients have gotten sicker. Some of our patients, the heart has, as the patients live with heart failure, other organs have become affected due to hypoperfusion from the heart failure, but also there are other pathologies that involve both the heart and the other organs. And whereas previously some of these patients may not have been a candidate for any procedures, now we would consider them for multi-organ transplantation. So our heart kidney program started in 1992, and since then we have performed 58 heart kidney transplants. Our heart liver transplant program started in 2006, and then we have done 18, and our heart lung has started in 1991, and we have since done 44. But most importantly, you can see that over the last 5 years, we have seen a significant increase in the number of patients who we offer dual organ transplant to, particularly with the heart, kidneys, and the heart liver. The survival in these patients have really been quite good, and our median survival for most of these transplants are around 10 years. When it comes to heart kidneys, this has led to a bit of a dilemma. Often when patients come and in need of a heart transplant, they can have cardiorenal syndrome, as well as sometimes acute renal failure. And if we do a heart transplant for these patients, maybe a subset of these patients will have full recovery of their kidneys. However, many of them do not. And it is often very difficult to predict which patients will do well and which patients will not. And if we guess wrong and do a heart alone, you can see that the patient will have a survival disadvantage if they remain on dialysis afterwards. So to protect the patients, what we have typically done is to offer both a heart and kidney transplant to patients with both cardiac and renal failure. However, this may be overkill in a subset of patients. So what UNOS have done in the last year, since June of 2023, is to provide a safety net protocol where patients with both cardiac and renal failure, instead of getting both a heart and kidney transplant, we would go ahead and do the heart alone. And after 60 days, if the patient's kidneys fail to recover, then they could get listed for kidney transplant at a higher priority. And this alleviates the need to do a heart kidney on patients who may have potential renal recovery. The way we do heart kidney transplants have also fundamentally changed over the last 5 years or so. Now, just like Dr. Soltesz presented, there are preservation machines for hearts. There are also preservation machines for kidneys, where the kidneys can remain perfused and viable for 48 hours after procurement, and sometimes even longer. And this fundamentally has changed our workflow, whereas before we had to do back-to-back heart transplant and kidney transplant, and sometimes the kidneys have to be done in a setting where the recipient may be bleeding, they may be hemodynamically unstable, and that kidney has a very little chance of working immediately after transplant. Now, with these perfusion pumps, it allows us to take a step back, do the heart transplant first, recover these patients in the ICU, make sure their bleedings are under control. We would dialyze these patients for 24, 36 hours and make sure that they're metabolically absolutely optimized before they would then have their kidney transplant. And often we would see immediate renal recovery and the urine production in these very, very sick patients. Now, what we've also specialized in over the last few years and market ourselves on this is special populations, particularly amyloid. I'm not going to steal Dr. Najim's thunder, but failing Fontan is another special population that we've really been able to help. We're one of the largest amyloid transplant programs in the world, and many of these patients require dual organ, either heart, kidney, or heart, liver. Now, failing Fontan's is a population that's really quite unique, and in my opinion, there is no harder operation in any specialty than a heart transplant or a heart liver transplant for failing Fontan patients. If you look at the literature, the mortality for these patients are about 15 to 30% acutely after a transplant. In other words, the mortality for failing Fontan to get a transplant is about 5 to 10 times higher than a standard heart. But the reason we do it is if they do survive the transplant, their conditional survival is as good, if not better, than almost any other populations. And to be able to successfully do these operations takes a collaboration between not just one or two, but 3 surgical specialties: congenital heart surgery, adult heart surgery, as well as liver transplantation. So when it comes to multi-organ transplant, although we have seen an increase over the last few years, it is a very measured and careful increase that we have done, and we do this better than any other centers in the world, and we're able to achieve the results that we get because of our multidisciplinary collaborative approach. Thank you very much.
Great. Thank you so much for the invitation, and thanks, Mike. This is a good segue for the congenital heart transplantation. Is it any different? And indeed, it is actually quite different. And why is it different? We've got a lot of areas that we have to address. One is the patient height and weight. So the match is not as simple as it is in adults. So we have to make sure that that's why the availability of organs is not that readily available, because of the differences in sizes and weights of different patients. Antibodies. Most patients have had previous surgeries, have been exposed to blood and previous surgeries and transfusions, as well as homografts, which increases their rejection possibilities. Organ availability, as I spoke, because it's very difficult to find a newborn that is going to donate a heart because of a brain death or something. So these are important issues. Heart versus heart-liver transplant, again, as Dr. Tong was talking about, they are multitude more complex operation rather than just a heart transplantation, especially when you have failing Fontan physiology. Almost all of these operations are redos because they've had a first attempt of a congenital heart defect repair and then came to a transplantation. Very few will have dilated cardiomyopathy. Anatomical consideration, and this is where we actually have a smaller group in every patient who is listed for congenital transplantation, where we sit around, talk, and look at the axis. We look at the anatomical consideration for every patient. So dextrocardia, you're not going to get a dextrocardiac organ donation. So you're going to have to change that dextrocardia and redirect it too. So you have to redirect the veins, the situs inversus, the heterotaxy, mesocardia, all these things that have to be looked at before surgery. Bilateral superior vena cavas, dilated, short SVCs, large SVCs, all these happens in congenital heart. Atrial reconfiguration or reconstruction, that patients who've had a previous atrial switches and arterial switches, mustard and sending procedures that have to be also addressed. Reconstruction of the ascending aorta, not unusual that they have conotruncal anomalies and they have huge aortas, and I'll show you some of these pictures. Residual obstruction and coarctation that has been addressed in the infant or neonatal period that still is there. Branch pulmonary artery reconstruction, distortion, stenosis, surgical occlusion of the Fontan, reconstruction of great veins that needs to be done for a patient who had a Fontan, ligation of residual surgical shunts or collateral. So all these things have to be addressed before. And over and above that, and we also talk about it every time that when we have a smaller group to discuss this all the time, access site. These patients have had multiple previous surgeries, probably 10 or 15 CATs before, so occlusion of peripheral vessels, access to cardiopulmonary bypass. We've gone very far with how to innovate and even getting access, even doing a laparotomy or doing a cannulation of the descending aorta when we do a liver transplantation. All these innovative ideas have to come, and it's all tailored for each patient separately from different from another patient. So each one would have a dedicated discussion between the leaders of the adult transplant team and the congenital transplant team, as well as the liver. This is just some of the examples of sensitizations. You see it really, see PRAs of 197 and so on and so forth. That's why, because they've been exposed to multiple previous surgeries. Now, why do we also have problems with the high-risk congenital? So as you see, even patients with tetralogy fellow, you still have to have a wait time, the sensitization, the coagulopathy, elevated atrial pressure. When you go into the transposition, they're always having PA pressure elevation, which presents a serious problem for the coming in right ventricle. Arrhythmias, this is quite frequent in patients with congenital heart. And then you start getting into the single ventricle Fontan physiology, where you get the protein-losing enteropathy and the liver disease that is associated with Fontan failure. And they represent really a difficult problem that we have to deal with post-operative. And that's why there have been risk scores that have been developed to assess the Fontan or the single ventricle failure. And these are scores based on these multiple organ dysfunction that creates a score that can affect the outcome. Over and above, those patients with congenital heart disease have been in and out of the hospital many times in their lifetime, and they have some anxiety, depression, some even frontal lobe disorders, mood disorders, and so on, as well as some of, obviously, the younger ones are, the parents are the primary caregivers, are the patients themselves. Some of the examples of abnormal aorta. So this is an aorta which may look like you may actually get a safe resternotomy. However, where you're going to clamp this aorta and how are you going to get that 2.5 centimeter donor aorta into this anastomosis. This is where we think circle rest, alternate site of cannulation. How can we reconstruct that smaller aorta to this large aorta? Atriopulmonary fontans, huge, and you see is how big they are. And you're going to have to deal with this. You're going to do a resternotomy safely and make sure. And then timing becomes an issue. Where are you going to put the heart? And this is all going to be, is it going to be warm ischemia, cold ischemia? When do you actually open the patient and go on pump? All these have to be thought of prior to bringing the patient into the heart into the operating room. And that's why we've developed the technique of reopening the sternum very safely before going on bypass, so you don't have a prolonged bypass time and exposure. And then we do this with this roll track. And as a matter of fact, we've helped this company to develop this technique to open the sternum with the least number of injuries of the cardiac structures. Some of the contributions that we've had, technical contributions that we've had to the transplant anatomy. This is a patient that we've done actually 2 of them or 3 of them recently, who came with partial anomalous pulmonary venous drainage of the recipient with a cardiomyopathy. So this is a patient where we leave the anomalous veins to the SVC, the recipient SVC, and combine that with the left atrium, the recipient left atrium. Thereby, we avoid reimplantation of these sinus venosus defects and the anomalous coronary veins. Another thing that we've learned through the biventricular conversion program and the ventricular switch here, that we can translocate one SVC to the other SVC and make sure that, so with patients with bilateral SVCs, we can translocate one to the other. And actually, recently I failed to put the picture that a patient that I did with Dr. Tong just like 2 weeks ago, where the patient had a fontan and we translocated the LSVC to the innominate vein, just as you see on the picture on the left side. But we did it in front of the aorta because long enough, it really came beautifully together without having to translocate. And so what you need is a lot of donor innominate vein and SVC to make sure that you can reconstruct that. This is some of the pictures. If you have a fontan, it's a lot of collaterals. It's a huge operation, and its magnitude to repair the SVCs, the pulmonary arteries, and the aorta. The position is also important, how you can do this, dextrocardia versus a situs inversus. And we can almost always convert the patient from a dextrocardia to a levocardia with just some techniques like translocating the left superior vena cava to the right side and then extending the IVC, and you can still implant the heart. You need to open the pericardium on the left side to accommodate the apex of the heart, but this has something that we have done. There have been some reports of actually putting the heart, flip it anterior to posterior and leaving the patient in a dextrocardic position. This is something I personally don't like. Hypoplastic left heart, we need the donor aorta to reconstruct the arch as well as the pulmonary arteries. And if we look quickly at the data, if you have congenital heart disease, the outcome of that is not the same as dilated cardiomyopathy. And if you have a VAD patient before surgery, there is a lot of attrition of those patients who have been in VAD before the congenital heart surgery compared to just cardiomyopathy patients. And similarly, the outcome of VAD for a single ventricle or biventricular, if you had a VAD before, is actually the same. So once you have a VAD and you move on to a heart transplantation, you're actually going to have good results or equal results. Hepatorenal dysfunction, as been mentioned, it's a major problem for us in patients with fontan, with single ventricle, and they do affect the outcome of the procedure. And this is the MELD score, where if you have the higher MELD score, you're going to have higher mortality postoperative. And if you don't have it and you have no PLE, the chance that you have a much better outcome. And the last slide here is the comparison between the heart and heart-liver. So if you have cirrhosis, you have heart transplant, no cirrhosis, this is the best outcome. You have it with cirrhosis, the worst outcome. You have heart and liver transplant, and this is the best way when you have liver. Thank you so much.
I'm not talking about Cleveland Clinic outcomes. It's actually nationwide, but we've heard some amazing talks, and we are going to go over outcomes. Okay, well, I have to begin with disclosures. My only is that the research you're going to see was NIH supported, and it gives me an opportunity to actually just introduce you to the two people who really have made this possible. Dr. Hemant Ishwan is a statistician at the University of Miami. He actually does machine learning and is really one of the founders of random survival forests. And Dr. Eugene Blackstone, who you may all know, is a renowned statistician. He's also a surgeon and has really contributed a lot to what you're going to see. So I have only 3 objectives. I want you to know the expected survival and the causes of death. I want you to recognize that there are 3 phases of survival, and it's logically going to make sense. And then I want you to know the risk factors. And we've kind of heard some of these. So the average survival, we tell a patient that they actually will live 10 to 15 years. We heard actually from Dr. Zaki, LVADs have 5, so if you combine the 2, you can picture a much longer survival. Based on old data, but it's actually our best data, the international data shows that actually men live a median of 11.4 years, and women 1 year longer, 12.2. And this is true with the US as well. So what do they die from? In the perioperative period, I want you to see, let's see if I can put the pointer, that the pink is graft failure, so the graft doesn't work. Okay, that's called primary or secondary graft failure. So it just doesn't work from the start. That doesn't have a good outcome. Multi-organ failure is next. So we talked about the fact, Dr. Finette talked about how patients are coming in with our new system in shock, getting advanced care, and then being rushed in. And we're going to go back over it, but the outcome is not good when you actually have multi-organ failure. And then the last is actually infection, and that is nosocomial. So we like to get the patients out of the ICU. We want to deline as fast as we can. So why do they only live 10 to 15 years? What's going on at the end? At the end, malignancy is a very high rate. You may not have had cancer before. Maybe you wouldn't have ever had it, but now you have a much higher rate of cancer. The second is graft failure, but these are the grafts that worked. Now they're failing actually because of allograft vasculopathy. There's a lot of blockages and teeny vessels, and so that leads to graft failure. The third is infection, but the infection is no longer nosocomial, it's no longer opportunistic, it's actually community acquired, such as COVID, right? Took out a large number of our transplant patients. And then we have other findings such as renal disease as well as just pure allograft vasculopathy. So this was actually something that is very logical, makes sense, just wasn't shown before, and we had demonstrated that there are 3 phases of survival. The first is early, then there's late, and then there's a constant risk. What I want you to notice is the duration and actually the rate of mortality. So we're going to start with early, right? Early lasts, you have the highest rate of mortality within the first few months. In fact, you have an 8% mortality. And it all is up front. And then it levels off. And then what you see is it extends up to 4 years. After 4 years, you have a late mortality, and the steepest part of that curve is actually after 10 years, right? It gets very steep. And then there's this constant risk. And I just showed you that women live longer. This is actually known. This is US data right now that we're looking at. And we never knew why. Did we actually make it through surgery faster, better, or what was the reason? And we now know that we just live longer, so it's a late phase. Each of these phases have their own risk factors, okay? And risk factors at the time of transplant best predict really things associated with that, so early phase, okay? And I color-coded it so that we can make it really simple. I want you to recognize that when we do these analysis, we take information from the recipient, we take information from the surgery, we take information from the donor, and when you put it all together, the perioperative risk is mostly recipient-based. That's why it's so important that we should extend our donor population pool with what Dr. Soltesz had suggested, which is the different transport systems, and start playing with taking some higher risk donors, because we don't have much risk with the donor. The state you are in at the time, the medical severity at the time of transplantation, dictates whether you're going to make it out. Super important. We heard from Dr. Finette, ECMO is bad. It is our tier 1. We got to save you, but ECMO remains bad, okay? And then we heard multi-organ failure. We were going from shock, rushing people in, and that's not good. We know that actually, renal failure is mostly predicted by renal failure going in. And so what you see here, and I want to kind of point them out, bilirubin represents our liver. That's high risk. I want you to see that respiratory failure, which is ventilation, even if it's reversible from heart failure, is also our risk. And then you have actually dialysis and renal insufficiency. And these end organ dysfunctions are not part of our tier system. With regards to surgery, ischemic time is important, okay? And that was based on ICE. And so it's important that these other systems preserve better. And donor, really only age keeps popping up in everybody's analyses. Constant phases are actually several. As you get older, the donor gets older. So it makes sense it's a constant risk every year. And actually the recipient is young age, which is more related to the fact that a young person has a more robust immune system, and they are not always the most compliant in taking the medication. They're not used to it. I think it's important. We knew that actually Black patients have a higher rate of rejection, and we didn't really understand why. There's a constant risk, and it's actually very multifactorial and very interesting. But one of the factors is we don't actually have a perfect way to match. So it ends up being that they're at risk for rejection, even for something like that. And then the other I want you to point out is Medicaid. So for socioeconomic barriers remain a concern. Late phase has few because these are variables at time of transplant. So 10 years later, they're not important. We learned actually that malignancy, allograft vasculopathy, and all these other factors cause death, and what happens in the beginning does not really affect that. I was always very impressed by our EP staff that actually made these heat maps to identify the arrhythmia focus. And I thought, oh my God, I want one of those. So I call up our statistician in Miami and I said, make me a heat map. I want it really visible to know which factors are the highest risk of death. And so this is with machine learning. And what you see is anything that is dark blue is bad. Combinations in dark blue are bad, and those in pink are really no big deal. But what you're going to notice first, if we look at 90 days, the perioperative, and that's really the only one we're going to focus on, I want you to recognize that factors related to the device ECMO are not the worst thing. It's actually these multi-organ failures, right? So if you're on a ventilator at time of transplant and on dialysis, high mortality. If you have a ventilator with actually liver dysfunction with bilirubin, bad. So you combine liver and kidney, all these things that when you have shock at time of transplant and you rush them through, they do not do well. And they're more important than other factors. The data I showed you preceded the change in the allocation system, and it's been replicated actually by Dr. Parker and colleagues from the University of Chicago. And so this is based on the new policy that we have, 2018 onwards. It's the first couple of years. And you'll see the same thing. He creates a heart transplant risk score, and what I want you to recognize is that the recipient factors play out to be the most important. Again, letting us feel more comfortable with everything else. Ischemic time matters, but assuming on ice, okay, because that doesn't hold when you actually have these other preservations, donor age. But it's the same, ECMO, ventilator, renal failure. And in fact, ECMO is, ventilator is actually 2 points. And renal failure is also 2 points. And why am I pointing this out? That one risk factor does not actually put you at the most risk, it's the number of risk factors. So at our meeting all the time, you know, people talk about the fact that I want a rule that says, you know, cutoffs. And I always say that the data for equity, data shows actually that the number of risk factors matter. So if you are older, two people the same age may have different risk mortality. Two people the same age may have different risk mortality if they have liver dysfunction. It is important to count the number of variables because that actually changes significantly survival. So in summary, there are 3 phases of survival. Mortality risk factors are associated with each of these. And I think I want to really point out that the recipient's medical condition at the time of transplant dictates the perioperative risk. Even if it's a reversible thing, it doesn't reverse that fast. And when we give a lot of fluid and we go through surgery, we really need to reverse what we can ahead of time. And with policy changes, we always have to assume that actually everything changes. So we do need to repeat our analyses.
Thank you, Eileen. For the last few minutes, I just want to see how that patient did, our status 2 patient, what kept you up, and Dr. Zaki up at night a few nights ago.
Yeah, we're back to our case presentation. He's 60 years old, non-ischemic cardiomyopathy with ejection fraction 15% and recurrent VTACT. We accepted offer of DCD, the donor, and we use OCS, and Dr. Soltesz has already talked about the OCS. And at this same time, the heart was taken as OCS device, and the liver was taken by NRP at the same time. This is the heart when it came to the operating room. Time of OCS perfusion was 5 hours and 20 minutes. First ischemic time was 48 minutes, and second ischemic time was 55 minutes. Heart was implanted and ICD was removed, and currently the patient post-op day 2 is awake and weaning the ventilation with minimal support, and RV, LV is mild dysfunction, and he has some AKI with good urine output. He's paced as atrial pacing at 90 and MAPS is 70s, and index, FIC index is 4.1 and mixed venous 71, and normal lactate. Thanks.
Thank you, everyone, and thank you very much for attending Tall Rounds this morning. It's 8 o'clock, so we will finish it up. Thank you.